To start with, let me thank Dr. Jackson sir for this opportunity. See, the technology is evolving every day. What is new today is old tomorrow. Especially in science, it's evolving in such rapid pace that it is very difficult for us to actually evaluate it and start using it. So today, I'll be speaking on few newer gadgets in IVF and how its impact is on the current pregnancy rates. To make it more simpler and make it a little more easier for you to understand, I'm primarily dividing them into three particular groups. One group to actually used for sperm selection, another group is for oocyte selection or insemination timing, another group is for embryo development and embryo selection. See, we are going back to what is in the nature. See, the basic principle of oocytes, for example, sperm selection, was that naturally the sperms go and attach onto the zona or the hyaluronic acid, and that is when the sperms enter the oocyte. So using the same principle, once they studied that the sperms which go and bind onto the zona are the ones which are having better nuclear maturation, better morphology, less aneuploidy, and lesser DNA fragmentation. There are several techniques what came in, but one of the most important ones being the PICSI or the physiological ICSI. We have the zona pellucida bound sperms were taken up and used for ICSI, and the cumulus cell penetrated sperm. PICSI is currently available commercially as particular dishes where we can add the semen sample onto these dishes, incubate it for a while, and after you rinse it, we are able to get and again see these same dishes under the microscope. You'll be able to see sperms which are adherent onto these droplets. So these sperms which are adherent are aspirated, and these sperms are used for ICSI. So these sperms are considered to be more mature, more better, and are giving us better fertilization rate, better pregnancy rates, and even we are having higher quality, better quality of embryos, which have been proved in several studies. Even when we are looking at zona pellucida bound sperms, we are looking at sperms which say a droplet, and we add with egg, and we add in the sperms. We can actually go and select the sperms which are getting adherent onto that zona, and those sperms used, and when ICSI was done, even that gave us a statistically significant higher quality embryos in this particular study. This again is another study which talked about a cumulus which is kept inside the capillary, and when this capillary tube is kept over a droplet of semen, you can actually the sperms which are good will swim up above the capillary phase. So you can actually select these sperms which are here and use them for ICSI. Now coming to another technique of sperm selection. See, this technique basically came from the theory that any abnormal sperm or any sperm with defects generally tend to have some defects in the surface epithelium. So once the surface epithelium is defective, the inner layer gets exposed. That is a phosphatidylserine layer gets exposed. So when we adding some annexin 5 conjugated supermagnetic beads along with the semen sample, what happens is, and when you mix it, these magnetic beads go and attach onto the abnormal sperms. So when you send these semen sample through a magnetic cell sorter, the sperms which are abnormal go and attach onto the magnet, and what comes out through the other end of the cell sorter are the significantly normal sperms. So again, when you're using these kind of sperms, it was proved that the better fertilization rate is there, a better cleavage rate and pregnancy rate, and these are the kind of sperms which are having lesser DNA fragmentation. But see, these are studies which came in, but we did not have a lot of consensus as to whether these techniques are actually significantly beneficial for the patients. Now coming to IMSI, that is intracytoplasmic morphologically selected sperm injection. Here basically what happens is you are selecting the sperms under higher magnification. This is the kind of magnification sometimes what you see when you're taking a sperm for ICSI, and this is what you see on a higher magnification. So this, and you select the sperms within a particular criteria, which was basically coined by Bartu et al., and it was called as the EMSO, that is morphologically selection of the motile spermatozoa. So you after enlarging the sperms, we see them under the microscope under high magnification and select these sperms. There are several systems available today. One is the OCTAC system, the LICA Big S, there is the RA system for IMSI. What we currently use in our center is a Eppendorf micromanipulator with the OCTAC system. See, of the several techniques which are available today, when you're talking about IMSI, see what is basically happening. We are going to examine and select a sperm in motion. So that in motion it is important because the sperms keep moving. So you'll be able to see all the parts of the sperm when it's moving. And for example, when you're talking about morphologically normal, you're looking at vacuolations and extrusions, intrusions into the heads. So when you see, these vacuolations are very significantly associated with DNA fragmentation. And currently we know that DNA fragmentation is one of the most important identifiable markers which are for causing ICSI failures. So in this particular video you can see the sperms which we were actually kind of examining and within keeping them inside a needle, because when you're working under very high magnification, the sperm just goes out of the field. So it becomes very difficult for us to actually hold that onto that particular place and start observing them. And you can see in this particular video there is a lot of abnormal sperms, lot of vacuolations, lot of abnormalities. So it became significantly important for us to identify these sperms and use these sperms for ICSI. This is a very interesting study which was published, which brought about cases, especially with at least 2 or 3 ICSI failures. They divided them into 2 groups, and they divided them into 2 groups, and in one group they did the conventional ICSI, another group they did the magnification ICSI. So what was very interesting, I think what a lot of people understood today was, especially in case of morphologically abnormal sperms, it is never the early division which is affected or the early development of the embryo that is affected. It is always the implantation or the further development of the embryo that is affected. If you can see here, the number of embryos were similar, but if you look at the pregnancy rate and delivery rate was significantly better in the IMSI group. This was a study done in our own center where we compared 203 ICSI patients with 114 IMSI patients. We could see a clinically significant pregnancy rate as well as a statistically significant pregnancy rate, especially in group with previous 3 or more failures, and also a lesser abortion rates in IMSI group. This is again a meta-analysis which demonstrated that there is no significant difference in fertilization between ICSI and IMSI, but the implantation and pregnancy rates are almost 3-fold in IMSI, as well as the abortion rates were much lower. So in our kind of a scenario, when we look at IMSI, we are looking at patients with repeated ICSI failures, we're looking at repeated fertilization failures, repeated abortions, unexplained infertility, and to a small extent in abnormal sperm morphology. Now coming to the mechanisms where we can select the egg. Today we have facilities available like the polarization microscope, where today we have software is available which will calculate the kind of the zona bifringence, and the kind of a value is created, and once that value is created, we will be able to take that particular egg which has got the most probability of becoming a better embryo and which has got a probability of getting a single live pregnancy. And if you're looking at the, if you can actually see in this particular video, you can actually see this the M1 becoming an M2, metaphase 1 oocyte becoming metaphase 2 oocyte. This also helps us in idealizing the timing of ICSI. So once we are sure that the detachment happens between, once the polar body is completely out, it helps us then deciding that, okay, this is time for the patient to be, where the ICSI can be done. With the same polarization microscope, today we are also able to look at the spindles. So when you're looking at the spindles, it is always the concept that we used to keep the polar body at 6 o'clock or 12 o'clock position before doing ICSI. But a later consensus came that not necessary that always the polar body and the spindles are at the same level. So while injecting, there's a chance that you can damage the spindles. But in majority of the time, we've found out that whether majority of the time the polar body is always very close to the spindles, and will be, even if you do an injection, it's most unlikely to damage the zone, the spindles. Even the meta-analysis which demonstrated that even though there is better fertilization and embryo development, the clinically significant endpoint, that is the pregnancy rate and implantation rates, were never improved. For example, now coming to the embryo selection. Today we are looking at something called as embryoscope, or a time-lapse imaging of an embryo. See, generally what happens is we observe an embryo today, we observe an embryo day after, tomorrow morning. So what happens in this 24 hours from today till tomorrow morning is something which we do not know. So today we have incubators available where pictures are taken in interval of every 5 minutes. You join these pictures together and a video is created. So we'll be exactly able to know when an embryo becomes, if for example, for the time taken for the embryo to become a 2PN, then from 2PN to 2 cell, 2 cell to 3 cell, 3 cell to 4 cell, how it happens we'll be able to No, and see, with the help of this particular technique, they have created a particular nomogram for which they are able to actually decide as to say this embryo has to go from 2 cell to 3 cell to 4 cell in a particular time. So if the embryo is going beyond that particular time or the time frame is abnormal, then we are able to remove those embryos and use the embryos only within the particular time frame and use these sperms. For example, in the, use these embryos. And not just that, if you look at, see, for example, you can see this 2PN suddenly directly dividing into 3PN. See, these abnormalities were never seen earlier. We did not know these kind of abnormalities ever existed. For example, you can actually see, in the end, you have a very good day 3 embryo. In this patient, you can actually see a lot of fragmentations which were there. But once the embryo starts developing on its own, it developed into a very good day 3 embryo. So when we are looking at in certain intervals, we are never able to see these changes which come and go, and we are never been able to understand whether these abnormalities were actually there or not. So by actually identifying these abnormalities, we are able to select better quality embryos, and we have systems available called as the proteomics, metabolomics. See, these are things like, say, proteins which are used by these embryos, and these are calculated from the media which are used for culturing. And once, see, these kind of proteins which are either utilized or the metabolites which are either excreted. So you calculate these items and then come out with a algorithm saying that the embryos which are using these metabolites at a higher level are the embryos which are better, or certain embryos which are using these metabolites at a lower level are poorer quality embryos. And today, PGD or PGS did come in a big way at one particular point of time, but today it really lost out because at that point of time we were only about to do it with fish. But today, with the presence of a CGH array, we are able to select embryos. I would not rather say select embryos. You see, it is two different things. When you're talking about PGD, it is pre-implantation genetic diagnosis. Especially, you're looking for a particular thing. Whereas PGS is screening. You are actually looking at the embryo and seeing if there is any abnormality. So either we can do a biopsy of the polar body, you can do of the cell, or of a blastocyst. So what basically happens here is, if you're looking at a diagnosis, we know that we are looking for a particular disease in the patient. The patient is supposed to have a baby with a particular abnormality. You can go in for a diagnosis. But especially in patients with some kind of an abnormality, or the patient is having a repeated implantation failure, a patient who's an older age group patient having a higher chance of an abnormality, in those category of patients, it is important that we are able to select these embryos using this particular technology. See, for example, in this particular data, you can actually see 89% of the embryos in patients with age of more than 40 years are abnormal, or 62% of the embryos in patients with more than 3 IVF attempts are abnormal. So we can use this technology in this particular subset of patients and use that and select embryos, so which can give us a better outcome. So to conclude, PIXI, whereas sperm selection is concerned, PIXI and IMSI are currently available commercially, and it is showing quite promising results, but we still do not have randomized controlled trials to tell us that whether these techniques can be used in our routine clinical practice or not. Whereas polarization microscopy is ideal in a research setup, but again, we're talking about using it clinically, it is difficult and still not proven. Whereas in the technologies which are involved in embryo selection, like the morphokinetics or the embryoscope, there are several ongoing studies which are going on, and I personally believe it can sometimes revolutionize the way embryo culturing is done and how embryos are selected. But today again, we need more studies for that to be proven on. PGD definitely is useful in specific category of patients for embryo selection, PGD, whereas PGS looks promising, especially in this special subset of patients where we can select embryos in a better way. So thank you all. Thank you for patient hearing, and let me finish off by this last session saying that, see, all this technology are brought in to serve our patients better. So as doctors, it's a sole responsibility to understand the purpose and the benefits of this technology, evaluate its risks, and use it carefully for the right group of patients whom it will benefit the most. Thank you for your patient hearing.
Thank you, Dr. Parasuram.
Yeah, and one last message. I think let me welcome you all to the next year Academy of Clinical Embryologists annual conference in Cochin from 18 to 20th September. Thank you.